Plan, Do, Study, Act, a Quality Improvement Initiative presentation by Mina Hanna, Christian Lewis, and Laura Reed. Plan, Do, Study, Act, PDSA is a four-step quality improvement model that guides the thinking process by breaking down the tasks into steps, then evaluating the outcome, improving on it, and testing again, according to the Agency for Healthcare Research and Quality, 2024. Four steps of PDSA, which can be repeated as a part of never-ending cycle of continual learning and improvement, according to the Deming Institute in 2025. Plan is identifying a goal or purpose, formulating a theory, defining success metrics, and putting a plan into action. Do are components of the plan are implemented, such as making a product. Study outcomes are monitored to test the validity of the plan for signs of progress and success or problems and areas for improvement. Act is integrating the learning generated by the entire process, which can be used to adjust the goal, change methods, reformulate a theory altogether, or broaden the learning improvement cycle from a small-scale experiment to a larger implementation plan. Application of the PDSA asks three questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvement, according to the Minnesota Department of Health in 2025. The history and background, or the origin and evolution of the model of the PDSA. The origin of modern scientific thinking began in 1610 with Galileo and evolved through 1993 to the Deming PDSA method, according to Flinchbaugh in 2021. The method originated from history and manufacturing by Shewhart and Deming. Before PDSA was the Plan, Do, Check Act, which Deming thought held back the process from his teaching in Japan, according to Bell, et al. In 2014. The timeline illustrates the evolution of the PDSA cycle and the many influencers into the current model of lean and continuous improvement. You can see those influencers in the model on the right. Key concepts and tools. The Ishikawa, also known as the fishbone diagram, assists with brainstorming the cause and effect relationship for solving a problem and provides the information in a visual tool, according to Six Sigma in 2015. Essential concepts of the fishbone are a problem statement, or the effect, clearly defined problem or effect being investigated, placed at the head of the fishbone. The cause categories are major groups of potential factors that contribute to the problem, represented as branches or bones of the central spine. Causes and subcauses are specific factors within each category that contribute to the problem, which are brainstormed and listed as branches of the main cause categories. Asking why does this happen repeatedly helps identify deeper levels of subcauses. The root cause analysis is the process of investigating beyond superficial symptoms to uncover the fundamental reasons behind a problem. The essential tools and techniques of the fishbone are brainstorming, the 5 whys technique, a flip chart or whiteboard and markers, and team collaboration.
So the PDSA model has shown tremendous value in healthcare, especially in tackling complex issues like surgical site infections. Because PDSA is iterative, it allows teams to implement and then refine evidence-based practices until the best results are achieved. For example, in pediatric cardiac surgery at a major US children's hospital, a multidisciplinary team used several PDSA cycles to refine their SSI prevention model. They enhanced patient hygiene, standardized wound care, and implemented daily monitoring, which resulted in a dramatic drop in SSI rates from 2.8 to 2.55 per 100 cases. Similarly, a tertiary hospital in India used PDSA-based approach to address a baseline SSI rates of nearly 30% in cesarean section patients. Through repeated cycles, they introduced staff training, stricter antibiotic prophylaxis, and surgical safe checklists. Their effort reduced the SSI rate to 5% and sustained this improvement over time. These examples highlight how PDSA supports the implementation, evaluation, and refinement of interventions, leading to measurable improvements in patient outcomes and broader systemic changes.
The factors contributing to surgical site infections, or SSIs, can be explored using a root cause analysis tool known as the fishbone diagram, also called an Ishikawa diagram. The head of the diagram states the problem, surgical site infection. The bones represent the factors that contribute to surgical site infections. The staff category includes factors related to healthcare teams and patients. Inadequate staff training on sterile techniques, poor hand hygiene compliance, insufficient surgical experience can all increase SSI risk. Communication breakdowns between team members are also critical factors. In the process and methods category, we examine the procedures and protocols that are followed. Issues here might include inconsistent surgical technique, non-adherence to antibiotic prophylaxis guidelines, improper skin preparation methods, or flaws in instrument sterilization processes. Even inefficiencies in operating room workflow can introduce risk. The equipment branch considers the tools used. Malfunctioning sterilization equipment, improperly maintained instruments, or issues with OR ventilation systems that affect air quality can all contribute to contamination and SSI development. In the materials section, we look at supplies that are involved. This could be anything from the quality of the surgical dressing, the type of suture material used, the efficacy of antiseptic skin prep solutions, or the integrity of surgical drapes. Substandard materials can directly impact infection risk. The environment category encompasses the physical conditions where care is delivered. Factors like OR temperature and humidity control, air filtration systems, and overall cleanliness of the operating room and surrounding areas play a significant role in preventing bacterial proliferation. The patient factors category, while not modifiable, helps us to understand patient comorbidities, nutritional status, skin condition, and immune system strength, as these can all predispose them to infection and impact their healing. The measurements branch highlights the importance of accurate data collection and surveillance. If SSI rates are not being measured precisely, adherence to bundles isn't tracked, or timely feedback is not provided, the ability to identify and address the problem can be compromised. By dissecting the problem of SSIs using this framework, specific areas for intervention can be pinpointed, and targeted strategies can be developed to enhance patient safety and reduce infections. This diagram provides a comprehensive visual representation of potential causes, helping to move from identifying symptoms to addressing the root causes.
Effective planning is the cornerstone of any successful PDSA cycle. When working to reduce SSIs, planning begins with thorough review and analysis of institutional data. We set specific measurable goals, such as reducing SSI rates by certain percentage when is set within a set time frame. Next, we use tools like fishbone root cause analysis to identify every factors that could contribute to SSIs, from process gaps and environmental issues to staff training and patient education. It is essential to involve a multidisciplinary team from the start, nursing, surgeons, implementation preventionists, and even patients and families, so that everyone is accountable and engaged. For sustainability, we embed new protocols into the EMR, develop audit tools, and ensure ongoing staff education. Having a clear plan for monitoring and continuous improvement ensures that gains are not just temporary, but become part of standard practice. Resources such as toolkits from the Minnesota Department of Health can also guide institutions through each step, emphasizing an interdisciplinary and sustainable approach.
The do element of Plan, Do, Study, Act. The do phase of the PDSA cycle for surgical site infections will be implementing the change and consider the contributing factors of surgical site infections identified in the root cause analysis. Staff will be asked to participate. SSI prevention education provided to all surgical staff caring for and interacting with patients, and educate patients and families in their roles pre and postoperatively to prevent SSI, according to MDH in 2011. Identify and implement appropriate use of immediate sterilization, cleaning and disinfection of instruments, equipment, and the environment. According to Kramer and Marani in 2023, preventing a surgical site infection can be accomplished by integrating perioperative measures, multidisciplinary collaboration, and continuous quality improvement. Before scheduling surgery, if able, address the modifiable risk factors and patient behaviors that increase their risk for infection. Preoperatively, patients receive antimicrobial prophylactic therapy, proper skin and site care and cleansing according to standards. Intraoperatively, limit the number of OR staff in the surgery environment and reduce the traffic going through the OR. Additional measures to reduce surgical site infections during surgery, including adhering to strict aseptic technique, maintaining patient norothermia, standard surgical attire, surgical drapes, and surgical site irrigation to decrease bacterial load, according to Kramer and Rarani in 2023 and MDH in 2011. Post-operatively, proper wound management with dressing changes, review antimicrobial stewardship, and timely discontinuation of antibiotics, according to Kramer and Rarani in 2023 and MDH in 2011. Collect data from the staff experience and adherence to protocols implemented, patient surgical site infection rates and outcomes, and the electronic health record data.
The study phase of the PDSA cycle assesses the impact of changes on surgical site infections. It involves data collection and analysis to determine effectiveness. Data is gathered from multiple sources: SSI surveillance, patient records, staff and patient feedback, and direct observations. Data quality through cleaning, validation, and standardization is vital for reliable results. Quantitative analysis compares SSI rates before and after interventions, evaluating trends and protocol adherence. Qualitative analysis through thematic review of feedback provides context on feasibility and impact. Assess intervention fidelity were the changes implemented as planned. This helps evaluate effectiveness, identify deviations, unintended effects, and lessons learned. The findings are then interpreted and presented in a comprehensive manner, detailing methods, results, and discussion. This report is shared with stakeholders and potentially disseminated through conferences or journals, contributing to broader quality improvement efforts. The study phase provides the evidence base for informed decision-making in the ACT phase, driving continuous improvement in surgical site infection prevention. The ACT phase is where the learnings from the study phase are put into practice, locking in improvements and setting the stage for future cycles of improvement. The first step is to standardize successful interventions. This involves refining protocols based on evidence and observed effectiveness. These refined protocols must then be seamlessly integrated into the EHR, enabling consistent application of best practices across the organization. This reduces variations in care and contributes to predictable, high-quality outcomes. Next, changes are disseminated and all relevant stakeholders are educated, engaging teams in providing targeted training on the new protocols, emphasizing the benefits and rationale is critical for buy-in and compliance. Communication should focus on actionable findings and demonstrate how the intervention can be integrated into existing workflows. Ensuring sustainability is key. Continuous monitoring of performance metrics related to surgical site infection rates and adherence to the new protocols is required. Regular feedback sessions and reviews help identify and address any new challenges or emerging variations, preventing regression to prior practices. This iterative approach allows for continuous refinement and adaptation, ensuring that the reduction in SSIs is maintained long term. The ACT phase transforms successful tests into standard operating procedure, solidifying gains and fostering a culture of continuous improvement in patient safety.
So, does the PDSA approach actually work? The answer is yes. The data support it. In the pediatric cardiac surgery example, the implementation of multiple PDSA cycles led to an 80% reduction in the SSI rate, a statistically significant change that was maintained for several years. This wasn't just about lowering numbers. Compliance with best practices like preoperative patient bathing and standardized wound care rose to over 96%. The cesarean section quality improvement project in India is another strong example. There, the PDSA-driven bundle led to a transformation in care, with SSI rates dropping from 30% to just 5%. Beyond the numbers, these projects helped establish lasting changes, like new checklists and protocols that became standard practice and fostered a stronger culture of safety and accountability. The key takeaway is that PDSA doesn't just achieve results, it sustains them by building improvement into the organization's daily routine, making lasting impacts on both patient outcomes and system reliability. Thank you so much for taking the time to check our presentation. And here are the references that we've used in our presentation. Please check them out and let us know if you had any questions in regards to our project. Thank you.